What are the contributing factors for having a contracture? The biggest nuisance is edema, and therefore it is not chymotrypsin which works, at least for me. It is the elevation above heart, and that too constant elevation that works. After a few hours, the patient said, I got pain in the shoulder elevating it. Yes, so teach them to strengthen her trapezium, levator scapulae, rhomboids. Stretch, stretch, stretch. Very important. If patient get tired, it's not painkiller that you give. You strengthen the muscles there. You strengthen the muscles there. Okay, I remember I forgotten rhomboid levator. So I say you have horizontal muscle and vertical muscles on the back. So if you do this, you are strengthening your horizontal muscles. Which are there? Rhomboids, levator scapulae. And you strengthen your vertical muscle. This is erector spinae. So I teach the patient and do it 5 seconds, relax. 5 seconds, relax. 10 times every hour. Every hour karna pada. Yeah, do it every half an hour. Every half an hour. Do it every 15 minutes. ज़्यादा नहीं पूछना if you are so 1 hour. So doing it morning, evening is inadequate. It has to be every hour. The next cause of contracture is poor immobilization. I'll talk about it. No, that's the worst thing. Cuts across, we'll talk about it. So there are various contributing factors. You have to overcome all these things. So what is poor immobilization? You have MP joint in extension, you have IP joint which is flexed. This is poor immobilization. Nothing can move in this thing. Whether even if you do flexor tendon, extensor tendon, this is absolutely no, because this defies any scientific knowledge why this has been done this way. So it has to be done, and you do it yourself. I said yesterday, if you want to die and if you want to meet God, you have to die yourself. There is no locum to meet God. So same thing, if you want a good result, you said you leave it to your junior, you leave it to your ward boy, and then you will have a problem there. And therefore, anybody helping you has to be well trained what you are expecting out of this. So poor immobilization, especially a volar slab which doesn't allow any movement. So have a dorsal slab, and again we have been talking again and again, MP joint flexion is an extremely important thing. We had displayed some of the splints yesterday. They are reusable, and therefore if you are using it say on 5 patients, the cost is distributed. Now no immobilization. If you keep your hand this way for half an hour, you see for yourself if that gets painful, and therefore immobilizing the wrist in flexion itself is a problem. Like if you have somebody has done a flexor tendon repair, you immobilize in acute flexion, not only they'll start getting a carpal tunnel syndrome, but this becomes painful, and therefore have at least a neutral position even if you are doing a flexor tendon repair. So there are stiffness, MP joint, usually it is in extension, but you can get in flexion also. Same thing about PIP, usually we'll see most of them flexion contracture, but you can get extension contracture, and we see plenty of these things. So if stiffness, if it is originally, primarily if the patient has come to you with a wound, if the skin is lost, replace. You suture it, is bound to get a contracture, and therefore primarily if you do a replacement of a lost skin, you can avoid it. You have to have appropriate incision, we'll talk about it, and appropriate positioning and splinting of course, and mobilize them as early as possible. And do not unnecessarily, we showed a lot of cases of this thing, unnecessarily immobilization, like external fixator across a perfectly normal joint can have a stiffness. Now we talked about this kind of this problem yesterday. This is one of the commonest problems that we see, whether you do phalangeal injuries or tendon repairs. Common problem is extension contracture. You try splinting. If splinting, draw a line how long. You tell the patient 3 weeks I'm going to try. If the disease is say about 3-4 months old with extension contracture, if the patient is already 1 year post injury and has an extension contracture like this, just don't waste time. They require a release. There are 2 ways of doing it. I'll talk only about one. What are the structures on the side of the extensor tendon at the joint? The sagittal band. You split the sagittal band, go there. What is there in the sagittal band deep? Deep to the extensor tendon, only one structure, and that is the capsule. Pick that extensor tendon, pick that dorsal capsule and cut as much far you can go. So you are starting on the radial side. See how far on far side you can go. Remove the capsule. If you go from superficial deep side, where are you? You are still in the joint. You are not going to cut anything, and therefore remove that capsule and bend it, and do the same thing on both all four. Rarely will be a situation that you are not able to access the ulnar side, and therefore make another cut in the sagittal band on the ulnar side and remove rest of the dorsal capsule. Once you have done this, once you have entered your capsule, you have cut, acutely flex it. At this point, either you put K wires in this position. I put lot of them, and I think I have stopped putting K wires here. Once you have achieved this, maintain this. You will be able to close this wound adequately, easily. If you put more suture, then you will put on a regular course, because this suture line is under a lot of tension, and put the patient to plaster 1 week, 10 days, whatever time, and then mobilize it. Now there may be situation you are not able to close, so make a counter cut here. Make a counter cut here, so you have a big flap, then close it, and this can be skin grafted. Now, so this was the extension contracture of MP joint. There will be scars on the volar aspect, they will give rise to flexion contracture, and this can be converted into Z-plasty to release this flexion contracture of the MP joints. I go to villages to operate. I've been going for 20 plus years. We see plenty of them, not 1, 2, 3. We see hordes of them. We see almost 300 plus patients in a day, and I together with 3 colleagues of ours and anesthetists also, we operate 102 days, 100 patients, 70 to 120 patients. Start from 8 o'clock to 11 OPD, 11 onward till 8 in the evening. We operate these patients without taking a break. And this was one of these girls who had this flexion contracture. All the fingers are buried inside, and we said, okay, we are going to release this. And sure enough, we released in the first stage the flexion contracture by putting a generous amount of full thickness skin graft. So this went on. We documented, and subsequent years when we go to the same place, we see to these patients are coming back for follow-up. After the surgery, we go back after 3 to 4 weeks to see them, and not only look at the wounds, document it, but also provide appropriate dynamic splints. Very important, coming to the PIP joint, no incision should cross the flexor crease. If you have a contracture, this has to be released by either a Z-plasty, skin grafting, or some kind of flap. We'll talk about it. Now, if the patient has a flexion contracture, the PIP joint, any or all the structures can be involved. Not only skin, flexor sheath, flexor tendon adhesions, volar plate, collateral ligament, or bone itself can be involved, leading to a flexion contracture, or for that matter even extension contracture. So whatever is affected, release it. How do you do it? Once you see that, try to extend it and palpate what you're seeing. The first thing, if your pressure is gentle, you'll feel the skin. If it is deeper, you can also feel, no, it's tight, it's too deep. But majority of time it will be skin contracture in a burn, deeper contracture in an injury. So so how do you approach? You go with the preparation that you are going to go right up to the bone. Each structure that you release, if it completes your contracture completely, that's under the treatment. But mentally be ready that you have to release all the structures, point 1, and how you are going to cover the contracture release. So let's talk about this. So there are various things you may require. Either you require splint, you require Z-plasty, full thickness skin graft, or one of the flaps, or it may be grotesque, very severe, that you will just stretch out with fixator, come back to rest of the surgery again. So early contracture will be because of a linear line across the flexor crease. Convert this with a Z-plasty. Your Z-plasty incisions, your incision should be volar to this termination of the creases. So first patient, flexion contracture, convert into Z-plasty, and this will do well, but it has to be supported with dynamic splinting post surgery. Other contractures, Z-plasties, splinting, good results. On the patient, skin deficit, you release this, but the moment you release this, there was question yesterday about what to do. So we release this contracture and put I'm very comfortable with putting hypodermic needle for maintenance of the correction, and after skin grafting and suturing this wound. Now if you deflate the tourniquet and the part has become white, provided you have not damaged the artery, majority of time almost nothing is going to happen at this point. But if you notice this is white, this is the time you have to be extremely careful. Hydration, warmth are two important things. After half an hour, just wait half an hour. Oftentimes the circulation will come back. If the circulation has not come back, the first thing you do after half an hour, 1 hour, maybe 2 hours is withdraw this needle and let it go back, because you don't want at least finger to become black. It may be symptoms may persist, that's fine, but you don't want a worse patient. So release this thing. Wait some more time, probably symptoms will be corrected. If you don't want to withdraw this, gently let the finger be bent, let the wire be bent, let the needle be bent. Probably the circulation will come back. If that does not happen, remove the needle. Circulation should come back. If still the circulation has not come back, then remove all the stitches. Invariably, if you have not damaged the artery, the circulation should come back by following these multiple steps. So we had this patient with contracture of the fingers following an electrical shock, and we released this. Flexor tendons were exposed. We talked yesterday, if any white structure like tendons, nerves, arteries, bone without periosteum is exposed, they require a flap. So sure enough, flexor tendons are exposed and we decided to put a flap. This was a dorsolateral flap. Stories I learned from Dr. B.B. Joshi. Some junior gave a cut and made a counter cut close by, and he was very unhappy. Now, how can you do these two parallel incisions? You are going to kill this. And the skin did not die. So he said, wow, two parallel incisions close to each other and the skin is not dead. And then started reading his anatomy. Oh, there is a dorsal branch of the digital artery. That was the evolution of dorsolateral flap. A coincidental finding, an accidental cut, and he realized the skin has not died. So that's how he discovered a dorsolateral flap. A dorsolateral flap, this from the dorsal aspect is broad and used to cover the palmar aspect, to cover the flexor tendon. So we could do the same thing on multiple fingers to correct the contracture. All the more necessary because he had already lost the other hand in the electrical injury, and therefore even this was very significant help to this gentleman, because he could hardly use this acutely flexed finger where flexed more than 90 degrees. Coming from the flexor side, we come to the extensor side. See where is the wound. This patient had some injury to the joint also, but his finger was in extension, and therefore this patient requires something else, and this was extensor tendon neurolysis. And after the extensor tendon neurolysis, acutely flexed and maintain the range of motion. The same thing can be on the DIP joint also. Incision release, full thickness skin graft from the hypothenar area or split thickness skin graft and correct this deformities. There was a question somebody asked about Dupuytren contracture. Dupuytren contracture. It's a benign, painless. So if somebody present with a flexion contracture, first thing you feel is the hardness here, a linear contraction. It is the thickening of the palmar aponeurosis, palmar fascia, and they starts from the nodule and becomes a cord to give rise to flexion contracture of either the small finger, ring finger, or the first wave contracture, or sometimes rarely into the sole also. So they have this. It's a painless condition. They can do full flexion, but extension is limited because of this puckering, scarring. The test you require, when do you see if the patient requires surgery? Tabletop test. If the patient is not able to put the hand flat, he is a candidate for surgery. If he can put the hand flat, the surgery can be delayed significantly. So tabletop test, he can't keep the hand flat, it starts to curl, it starts to bend, they require surgery. Differential diagnosis. You can see a cord in tenosynovitis also, but it's a linear thing. It is not involving the skin. In the Dupuytren, it is the skin which is also involved. In tenosynovitis, you can pull the skin away. In Dupuytren, the skin is puckered, it is scarred, it is adherent to the deeper structure. In neurofibroma, it is painful, it is not localized. So this lady had a lump here, it was very painful. We excised it, turned out to be neurofibroma. So once you have a Dupuytren contracture, what is the aim? Aim is to have a full range of motion after releasing the contracture in a patient who has a tabletop test. What about medicine? Splinting. Splints are not going to help. If it is going to progress, it is going to progress irrespective whether you use the splint or not. And medicines don't work. Physiotherapy doesn't help. There are various methods of treatment of Dupuytren are described. What we do is, you make a linear cut along the cord from the area where it is terminating up to where it is in the palm. After you split and open up the area, remove the cord very meticulously, saving the digital nerve, because sometimes the nerves are entwined around the cord and their extension. So first patient, a linear cut, excise the cord, save the nerves. Once you have completed part 1, this is part 1. Now your fingers which are extended, convert this. If you leave it at this, you are heading for a trouble. We just talked, a linear cut across a flexor crease is going to lead to flexion contracture, and therefore at this stage this has to be converted to multiple Z-plasties. So cover it with multiple Z-plasties. Leave part of this wound open proximally, because you are elevated from here, all the blood is going to ooze out. Don't close the proximal suture line so that the blood can come out. Sometimes there can be about a centimeter of skin loss also. Don't cover it, don't skin graft it, move it, and the blood can come out, and it heals much better if left open. So multiple Z-plasties. And enzymatic fasciotomy has been described. I have not used it, but whatever I have read, the results are not as gratifying as a surgery, and therefore this is okay for somebody who has very severe affection, is unfit for surgery in spite of whatever advances we have in anesthesiology. So this has been tried. I have no experience, but can help in some patient. Once the surgery is done, you immobilize in extension. We have been talking about immobilize in flexion, but this Dupuytren is one thing where everything changes. So immobilize in extension just for a day, maybe 2 days. 3 days is too much. Remove the plaster after 2 days and encourage the patient to move. Once you encourage the patient to move and he is taking rest, put the splint back in extension. In the morning he wakes up, he remove the plaster, move it. Second day, third day, when you remove the plaster, ask him to boil the water in pressure cooker. Let it cool down, very important, cool it down. And now immerse your hand in the cool down water. It is sterilized. It's those city mari usne. Then wash the hand. Whatever blood is there, it will come out. Again put the splint, because sometimes the patient is not able to come. So they can do these home exercises and mobilization. But splinting intermittently is very important, that to extend. If you don't, they get a recurrence of the problem. And you have already kept the proximal edge open, therefore whatever blood is collecting will express out. Recurrence is known, but there is a genetic difference in the kind of Dupuytren we see in our part of the country and you see around in the white population, and that too around the Mediterranean Sea, and therefore you don't see recurrence in our kind of population. So you are safe, but the mainstay of not getting a recurrence is splinting. Complications are there, loss of flexion if you have cut the flexor tendons, arterial laceration, but you are doing under tourniquet and magnification, therefore possibility of causing damage is much lesser. So in summary, Dupuytren contracture or any contracture for that matter is a benign condition, it's a painless condition. But Dupuytren, the indication for surgery is a tabletop test is positive. You excise it and convert it into multiple Z-plasty. Enzymatic treatment is available. I have not tried, but the results are far better if you excise it, and this has to be followed by splinting.